Continuing with our academic program, I invite Dr. Priyanka Pavithran, Senior Consultant Anesthesiologist, Aster MIMS Hospital, Calicut. Her achievements include Corps Award, ISA Con 2019 and 2024, Kuhas 2014 MD Anesthesiologist, Gold Medalist. Her area of interest include regional anesthesia and research and publication. The moderator for this session will be Dr. Ravi Vadakedath, Consultant Anesthesiologist at Leo Hospital, Calcutta.
Respected senior faculty and dear friends, a very good morning to all of you. So today I am here to update you on the developments in a very common intervention we perform in our routine anesthetic practice, which is the rapid sequence induction. So in 1946, Mendelssohn described the aspiration pneumonia and the comorbidities associated with it. And from then, several strategies were described to avoid aspiration. In 1961, Selig described the cricoid pressure, which was shown to reduce the chances of aspiration. And in 1970, Stept and Safar made a complete description of RSI by collating all these measures which were studied so far. So, rapid sequence induction was a 15-step process which was described initially with the goal of minimizing the unprotected airway time to reduce the risk of aspiration. But from then, several international surveys have shown a wide variation in practices with varying components of RSI being practiced by different practitioners. Now, this variability in practice may have been due to the lack of consensus regarding a definite definition of what RSI actually is, and also there is paucity of evidence on the utility and efficacy of traditional RSI. So, is RSI still the same? That would be a big no for the answer, because almost every element of the original technique has been challenged or adapted, mainly because there is lack of evidence on the utility and efficacy of the traditional RSI on its impact on reducing the chances of aspiration and improve patient outcomes. So, almost every element of the traditional RSI, starting from the drugs and equipment, have been changed, and we will have a look on every aspect of that. So, starting with the indications are one thing that is not changed, and RSI is indicated in two groups of patients: patients with adequate fasting but who are at high risk of aspiration, and patients in whom fasting is inadequate. And traditionally, RSI was described to be used in anesthetic practice, but as of now it is widely practiced in critical care, emergency medicine, and even pre-hospital settings. And even inside the theatres, there is wide variations in places where theatres where RSI is practiced, and it is most commonly and most religiously practiced in obstetrics. And you look into the aspects of pediatrics, again surveys have shown that less than 50% of the anesthesiologists practice RSI in their pediatric patients, mainly because it is not feasible due to the anatomical and physiological differences. The cricoid is smaller and more cephalid and more difficult to identify, and even small pressures can cause airway compression. Pre-oxygenation is difficult to achieve, and lack of intravenous access makes the situation all the more difficult. Now, we are moving on to the updates in drugs. Traditionally, predetermined doses of thiopentone and succinylcholine were used, but the main problem in this was avoiding opiates increase the risk of awareness. So, in the current scenario, an increased use of opioids is seen, with the fentanyl being the most commonly used agent. Additionally, propofol, ketamine and etominate are also being used as induction agents, with propofol being the most preferred agent. And succinylcholine was considered the gold standard because no other neuromuscular blocking agent matched its rapid onset and offset. But currently, an ideal neuromuscular blocking agent for RSI is controversial because you have two options of suxamethonium and its spontaneous reversal, or rocuronium and sugammadex for reversal. So, if you have a look at succinylcholine, it has an unmatched rapid onset and rapid reversal, but it is also associated with several adverse effects like the potential to cause hyperkalemia. Studies have shown that it causes more rapid desaturation during RSI in obese patients when compared with rocuronium, and it is the neuromuscular blocking agent with the highest risk of anaphylaxis and also has the potential to increase IOP, ICP and intragastric pressures. Now, previously aminosteroid agents were not considered for RSI because of their slow onset, but rocuronium is set apart by its fast onset because of its low potency. So, at present we have two options for RSI, scoline 1 to 2 mg per kg or rocuronium 0.6 to 1.2 mg per kg. And at low doses of rocuronium, scoline had a better intubating conditions, but if compared to high doses of rocuronium, both of the drugs had similar intubating conditions, and added on to that we have the availability of sugammadex, which makes rapid reversal from any depth of neuromuscular blockade of rocuronium, which is an added advantage. But again, we should be aware of the adverse effects of sugammadex, including the anaphylaxis, hypotension, arrhythmias and also the high cost, which is a major concern. So, this Cochrane review compared rocuronium and succinylcholine for rapid sequence induction and concluded that there was no statistical difference in intubation conditions when both of these drugs were compared, especially to a roc dose of 1.2 mg per kg. But succinylcholine was clinically superior because it had a shorter duration of action. In the equipment side, we have widespread availability of video cholecystoscopy and other difficult airway equipment, and also improved monitors, which makes our job easier, as well as the availability of gastric ultrasound helps us to evaluate the residual volume, which helps us determine the patients who are at high risk for aspiration. Now, the risk of hypoxia was not adequately addressed in the traditional RSI techniques. So, and this becomes all the more important when we are dealing with critically ill patients who tend to desaturate rapidly. So, some more techniques were adapted into RSI in the pre-induction oxygenation technique to improve the oxygen reserve of the patients. With these include the nasal apneic oxygenation, Thrive, gentle bag and mask ventilation and CPAP, and even some positioning techniques like head up and 25-degree rammed up. Now, the most debated element of RSI is the application of cricoid pressure, which includes applying a posterior force to cricoid cartilage with the intention of compressing the esophagus between the cricoid ring and the C5 vertebra. And this is to be done with the thumb and index or middle finger. A pressure of 10 Newton is applied in an awake patient, which is increased to 30 Newtons once the patient is asleep. And this pressure is to be maintained till the endotracheal tube is inserted, the cuff is inflated and the position has been confirmed with capnography and auscultation. This is a landmark study which created a paradigm shift in anesthesia, where Selig studied 26 patients being taken up for emergency surgery and cricoid pressure was applied, and he observed that the 3 patients regurgitated upon release of cricoid pressure after intubation, and thus proved the efficacy of cricoid pressure in preventing regurgitation. And this led to the, after this study, cricoid pressure was rapidly taken up into anesthesia and was made a standard of care. But years down the lane, several imaging studies questioned the possibility of a reliable esophageal compression with cricoid pressure, because esophagus appears to reside posterolateral to the cricoid cartilage, and cricoid pressure results in further lateral displacement of esophagus. And there is also a possibility that the structure that cricoid pressure is actually occluding is a post-cricoid hypopharynx rather than the esophagus. So, does cricoid pressure actually reduce the incidence of aspiration? The main concern we have is that the supporting evidence for this statement comes mostly from cadaveric studies and case reports. And then again, some more compelling evidence for this statement comes from the studies which have shown the efficacy of cricoid pressure in preventing gastric insufflation during mass ventilation. So, it is only logical to think that if cricoid pressure can prevent air from going in, it can also prevent gastric contents from coming out. And truly speaking, there is no RCT comparing the incidence of regurgitation with or without cricoid pressure in patients at high risk of regurgitation, and it is only logical to understand that it would be very unethical to do a study with avoiding a procedure that is the standard of care. Now coming to the negative effects of cricoid pressure, there is proven evidence of regurgitation despite application of cricoid pressure. This may have been due to a relaxation of the lower esophageal sphincter caused by the cricoid pressure, or it may be due to the inappropriate application or premature release. It has the potential to make intubation, mask ventilation and supraglottic placement difficult, and also causes airway and esophageal trauma. So this is an example of a videolaryngoscopic view where you can see the deterioration of the glottic view with the application of cricoid pressure. So this 2016 Cochrane review concluded on cricoid pressure, concluded that no RCT existed to support or refute the clinical use of cricoid pressure. This 2018 non-inferiority trial compared cricoid pressure and sham procedure, and their primary endpoint was the incidence of pulmonary aspiration. They noted that aspiration occurred in 10 of patients in the cricoid pressure group, whereas 9 patients in the sham group, and also noticed an increased difficulty of tracheal intubation in the Selig group. And these two recent meta-analyses have concluded that cricoid pressure failed to show a protective effect, and also it had the potential to prolong the intubation time and also to decrease the first attempt success at intubation. So another major concern has come into the realization is that the failure of the CP that has witnessed in these studies may have been due to the inconsistent application of cricoid pressure due to the various reasons. Now this throws a shadow of doubt on the results obtained so far. So again we are back to zero practically. Now having a look at what the guidelines say, many of these international guidelines have no longer recommend cricoid pressure as a part of as a routine practice, and it has been left up to the judgment of the practitioner. But the Indian Association guidelines as well as the Difficult Airway Society guidelines by the UK continue to recommend it, but recommend the release of cricoid pressure in the event of difficult laryngoscopy and intubation. So as I said, the cricoid pressure remains a very controversial area and we still have no consensus on it. The main limitation regarding the cricoid pressure was that it worsened the glottic view. But in this era of videolaryngoscopy, this does not seem to be a major concern. So at the end of this discussion, where do we stand? Should we apply cricoid pressure or should we abandon it? The main issues we have is that none of the guidelines adopt a firm policy to remove cricoid pressure completely. It is left up to the judgment of the practitioner because the evidence is weak. One major area of concern is that it has as these cricoid pressure still has a place in the guidelines, we can go up for medical legal litigations in case our patients, our documentation does not include evidence of RSI and cricoid pressure. So this study started looking for interventions other than cricoid pressure, and in this the author tried to the author tried to place an ultrasound at the left paralaryngeal side at the cricoid level in order to compress the esophagus. And they were successful in compressing the esophagus, but they had a difficulty in observing, visualizing the esophagus at this level. And this inspired Gautier et al. To describe the paratracheal pressure, which is the direct compression on the esophagus against the vertebral bodies and prevertebral muscles. And for this we have to place a thumb over the left side of trachea, cephalad to clavicle and medial to the sternocleidomastoid. So in this study they compared the left paratracheal pressure and cricoid pressure on its efficacy in preventing gastric insufflation, and they found that esophageal compression could be achieved successfully at the paratracheal level, and that paratracheal pressure was more effective in preventing gastric insufflation during face mask ventilation as compared to cricoid pressure. So let us have a look at what the evidence says when comparing these two techniques. In this non-inferiority trial, paratracheal and cricoid pressures were compared. The primary outcome was the incidence of deteriorated laryngoscopic view, and they had some other secondary outcomes as well. And the position of the esophagus was assessed by ultrasound in both groups. And they concluded that paratracheal pressure was non-inferior to cricoid pressure in the incidence of deterioration of glottic view. Mask ventilation was found to be easier with paratracheal pressure. increase in peak inspiratory pressure was significantly less in the paratracheal pressure, and other secondary outcomes were non-significant. So they concluded that paratracheal pressure was non-inferior to cricoid pressure with respect to the effect on glottic view, and the anatomical position of esophagus was more suitable for compression in the paratracheal region as compared to the cricoid cartilage region. Another study which demonstrated that paratracheal pressure was more, the insertion of ice-gel was easier with paratracheal pressure. And again, this trial showed that paratracheal pressure did not prolong the intubation time and showed comparable intubation conditions as compared to cricoid pressure. So another study which showed that this study showed a conflicting evidence saying that the occlusion of the upper esophagus was more effective with cricoid pressure. So this is all the evidence available as of now on paratracheal pressure, and we need more evidence so that paratracheal pressure can replace cricoid pressure in our guidelines. So coming to the last segment of my talk, as I already said, several surveys have shown the wide variability in practices in how RSI is done. This is mainly because of a lack of consensus. Now, PUMA, or the Project for Universal Management of Airways, an international collaboration of experts who proposed a set of universal principles for conduct of rapid sequence induction. So they recommended, suggested and optional components which should be practiced in RSI. And these components were described based on the consensus and current evidence. So the 10 recommended components were referred to the elements on which there is evidence or universal consensus, and they represent the defining aspects that must be included for your technique to be called RSI. And these include the pre-oxygenation, suction turned on and under pillow, you have a reliable IV access and tracheal introducer kept ready, a predetermined dose of induction agent, and rapid onset neuromuscular blocker administered with no latency. Apneic oxygenation should be done between attempts at laryngoscopy, and laryngoscopy is attempted after complete paralysis is ensured, and cuff inflation is confirmed before you start positive pressure ventilation. So these 10 components should be strictly followed if you want your technique to be called as RSI. Now the suggested components are those which should be included but should be omitted in specific situations in case of need, and these include apneic oxygenation during attempts at laryngoscopy. Before it was between attempts, this is during attempts at laryngoscopy, the ability to adopt a Trendelenburg position if regurgitation occurs, and suction and leave open to air and in situ nasogastric tube. And last one is optional components for which supporting evidence is weak, and practitioner can use their judgment for these components depending on the context. And these are the ones, and we need to make a note that cricoid pressure comes in optional components and is left to the discretion of the practitioner. So to conclude with, 60 years after description, RSI continues to evolve. Several developments have come up in all the aspects of RSI, but the principle of rapidly securing the airway after induction still remains same. Paratracheal pressure is being studied as an alternative to cricoid pressure, and the wide variability in practices is still seen, which again confounds the situation, and PUMA guidelines may address this variability and offer more clarity. So these are my references, and I thank you all for your patient listening.
Hello. Thank you, Dr. Priyanka, for the extensive talk on this topic. My own presumption is the cricoid pressure is likely to produce occlusion of the trachea for the reason that the longitudinal fibers of the esophagus has an attachment with the median ridge of the cricoid. So, if you give a cricoid pressure, it is more likely that occlusion is possible. More than that, cricoid is the only cartilage covering the whole circumference of the larynx, and it is stronger than the thyroid cartilage. So anyway, your suggestion that paratracheal pressure, we will try to practice that in our day-to-day.
Thank you, sir.
medical practice. Thank you very much.
Thank you, sir. Now, I request Dr. Ravi to kindly felicitate Dr. Priyanka. Now, I request Dr. Jo June Cheria to kindly come to the stage and felicitate Dr. Ravi. Thank you, sir.